It's now my pleasure to give you this talk on the indications for lead extraction. Well, I have no disclosures regarding this presentation. And everything I'll be presenting to you over the next 15 minutes will be taken from these two papers. The first one is the heart rhythm, the EHRA consensus, dating back to 2009. And Maria Grazia Bongiorni and Charles Kenegren, who are both faculty on this course here, were also co-authors on this very important document that really helps us, I think, deal with indications for lead extraction. There's another document here which is a consensus statement from the American Heart Association to deal with device infections. I think you all know how these guidelines work. Very briefly, a Class 1 indication is, in fact, recommends you to perform that procedure. Class 2A means that the procedure should be considered. Class 2B, that it may be considered. And Class 3 means it's not recommended. So I'd like to go over with you the different settings where you may be dealing with lead extraction, and start off with infection, which is one of the major reasons for extraction. Now, to diagnose infection, it's very easy when the patient comes in with cellulitis and a wound that's oozing pus, as in this case. And obviously, in this sort of situation, it's pretty clear and obvious that you need to take the device out, the leads out, treat the patient. Otherwise, he may actually die. What's more difficult is to diagnose chronic infections. And on the bottom left of the screen, you will see a patient, in fact, who has some adhesions between the device, the generator, and the skin. And if you just leave this, over time, it'll evolve to what you see on the right-hand side of the panel, with, in fact, exteriorization of the device and ulceration. Okay, my mouse is not working again. Sorry. Can you move the next slide, please? The mouse is not working. Here. Oh, it's got off the screen. Okay, thanks. Okay. So, we'll start off with this first question. You have voting pads in front of you, and you have this patient who comes in with this pocket here. You can see that there's an ulceration of the device, but otherwise the patient is not complaining. He has no pain, he has no fever, he's doing okay. So what would you do? Would you treat this patient with antibiotics and provide a skin graft to cover up that ulceration? Or would you operate him and place the box under the pectoral muscle to protect it from further exteriorization? Would you explant the generator and leave the leads in, cut them, cap them, and then implant on the contralateral side? Or would you explant the whole system, that's to say the generator and the leads, okay? And then, of course, reimplant. So can we have the voting, please? And you have 15 seconds to vote. So let's bring the question up and start voting. Okay, so let's look at the results. Oh, okay, 86%. Okay, so that's really the vast majority, and actually that's the correct answer. And according to the guidelines, complete device and lead removal is indicated in case of device erosion or chronic infections, okay? Because very often the leads are actually colonized, and if you do not take the leads out, well, the patient may have ongoing infection. Otherwise, the other indications, of course, if the patient has endocarditis, that's an obvious indication. It's also an indication, a class 1 indication, if the patient has persistent occult gram-positive bacteremia, usually staphylococcal. And it's a class 2A indication if he has persistent occult gram-negative bacteremia, where you don't know where it's coming from, but it's probably coming from the device. Okay, this is another case. This is a patient who's had a previous pacemaker, and he's had a recent box change. And the wound was not healing properly. There's this inflammation around there. So what would you do here? Would you clean up the wound, debridement plus antibiotics? Would you place the generator subpectoral? Would you explant the generator and leave the leads in and reimplant? Or would you take the whole system out? So again, can we vote, please? Okay, this time it's less clear. So there's a bimodal distribution. First, I think some of you would just do conservative treatment, and about the same number would actually again take everything out. So that's actually a close call. What do the guidelines tell us? Actually, the guidelines tell that for a superficial infection, just an incisional infection, as is the case here, the device does not need to be taken out initially. So you can actually treat conservatively. Of course, I think one has to be concerned about this, actually touching the pocket and then infecting the device. So these patients may be managed conservatively, but you have to keep a close watch on them. In this instance, the patient had the wound which was cleaned up and put on systemic and local antibiotics, and actually evolved favorably and had no problem thereafter. But you have to keep a close watch. So the indications for taking out the device surgically are very large vegetations. Some people may say 3 centimeters, some people may say 4. There have been reports of big vegetations up to 4 centimeters being taken out safely. Of course, the concern is that when you do have such large vegetations, that they embolize and may cause a big pulmonary embolus with hemodynamic collapse. Other considerations also for surgical extraction are shunts. Now, as you will be seeing in a case tomorrow, patent foramen ovale is not a contraindication to lead extraction, but right to left shunts are. So in these cases, it certainly is more safe to take the leads out surgically. And sorry about this, somehow it didn't come out very well with the file, but if you have another surgical indication, say the patient needs to have a valve repair at the same time, then obviously the surgeons, it's much easier for them to take the lead out at the same time. The second indications would be non-functional leads, and that's less clear-cut as to whether one should take leads out. There's much more debate there. So we know that leads dysfunction over time. This is a series from coming with ICD leads, and you can see that over 8 years follow-up, about 40% of these ICD leads will dysfunction. That's a pretty high proportion, maybe not the case in all centers, but these leads do fail, and that's certainly not exceptional. And the question is, what should you do when you have a failed lead? Do you take it out, or do you add simply a new lead? Now, there is a risk of these non-functional leads actually having possible consequences, such as in very thin patients lead to erosion of the pocket. You may have thrombosis, the more material you have in there, even though, quite honestly, there's not much evidence that the more leads you have, the more risk of thrombosis. We know that these leads, the ventricular leads, actually may adhere to the tricuspid valve and then cause tricuspid valve regurgitation. And you can imagine that the more leads you have in there, the worse the problem. The leads may migrate if they're not properly fixated and cause arrhythmias. And then, of course, if you have abandoned leads, especially in the ventricle, then it's a contraindication to MRI. You may also have interactions between the lead with the generator, short circuits for ICD shocks, and also between leads. And this is especially the case with integrated bipolar ICD leads, where the coil is actually part of the sensing circuit, and if you have two leads that touch each other, you may get what's known as chatter between the leads, with these artifacts, contact artifacts, being created. This is another case with a lead that migrated and was in the RVOT and gave, in fact, ventricular arrhythmias because of the lead irritating and tickling the right ventricle. and that may be potentially fatal, especially as this patient does not have an ICD implanted. In this old series, about 20% of patients who had abandoned non-infected pacing leads in fact had some sort of issue due to those abandoned leads, and the authors concluded that lead extraction techniques available, the issue of removal of all unwanted pacing leads should be addressed. More recently, there's another series here that shows, in fact, other data with very few complications. And the conclusions of this series is that one can actually abandon non-functioning leads, and it does not pose clinical significant risk for future complications. And this conclusion is also supported by this more recent series here in patients with ICDs who have a first implantation in green, in red an additional HV lead, so they abandoned the dysfunctional leads, and either adding a pacing lead or actually extracting the leads. And you can see that over an over 10-year follow-up, those patients in whom one simply adds an extra high voltage lead in fact have a relatively similar outcome in terms of complications as compared to those in whom in fact it was a first implantation. So this would also support the notion that the abandoned leads do not really increase the risk of complications. However, the authors do say that the recommendations may not apply for younger patients who have a very long life expectancy, in whom in the long term you may have issues with these leads. We know that lead extraction has complications. We'll be seeing a lot of complications over the next 2 days. This is just from a registry with Fidelis lead extractions, where we had there was about 8% of major complications. Another thing that one has to think about is collateral damage to untargeted leads, because, and this is just a series from Gooch patients, and you can see that about a third of those patients in whom the lead was extracted had collateral damage to the other leads, which means that those leads either have to be abandoned or also extracted. Of course, it will depend very much on what type of material you use to extract leads, and in this series, in fact, there were quite a lot of mechanical and also laser sheaths that were used. So the big question, should we extract all redundant leads? The answer simply is no. And the guidelines tell us that obviously if there are life-threatening arrhythmias, then the leads should come out. But if you have more than 4 leads on one side or more than 5 leads through the SVC, that's a class 2A indication. Otherwise, at the time of box change, you could consider it. It's a class 2B indication. So the considerations are the patient life expectancy, the potential benefit, MRI conditionality, of course, the numbers of leads, the risk of collateral lead dislocation, and that's especially a problem with coronary sinus leads, because if you do damage those leads or dislodge them, then you may never be able to use that very same CS tributary. And finally, the risk of other complications and experience with lead extraction, which is also very important. Very quickly, vein thrombosis. We know that about 9% to 10% of these patients with leads have chronic occlusion, and lead extraction is an indication in case you need to place a new lead and you have no venous access. Then you take out the lead to put the new ones in. And finally, the other indications are if you have a lead that may pose a threat to patients, such as the Acufix leads, but almost none of them are around anymore. And this is my last slide, talking about contraindications. So where you really need to have the surgeons to take the leads out are if the leads are anomalously placed or they go through structures such as the subclavian artery, the pleura. This is a case here where the lead actually perforated through the heart and through the pleura. It's better to have the surgeons take that one out. And also, if the leads are in the systemic circulation, then there's a big risk of emboli of fragments from the lead, unless, of course, the lead was just implanted there very, very, very recently. In all the other situations, it's better to have them taken out surgically. Okay, with that finishes my presentation, and I'll be happy to take your questions. Thank you.